Welcome to video number 2 of the ADA 2025 Standards of Care, and we're starting with section 5, facilitating positive health behaviors and well-being to improve health outcomes. The section starts emphasizing the notion that people really need to be referred for diabetes self-management education and support. And I couldn't agree more. My patients always learn something when they go for these either individual sessions or group sessions. And please send your patients for diabetes education because it's exceedingly useful. But then they go into these other recommendations, which I think are really important. I've been seeing a lot of people who are on GLP-1 receptor agonists or GIP, GLP-1 receptor agonist therapy, who are getting too skinny. And they really need to learn about what's a normal, healthy weight. So they now recommend to screen for malnutrition, especially in those who have undergone metabolic surgery and for those being treated with weight management pharmacologic therapies. And I think we do our patients a real disservice if they start losing too much lean body mass. So remember, you can be too thin. They do recommend a lifestyle that I recommend, which is to have plant-based proteins and fiber, at least to encourage that in the diet, and to limit foods high in saturated fats to reduce cardiovascular risk. They also recommend drinking water as a primary source of fluid intake, not obviously sugary sodas or even diet sodas. I try to encourage my patients to drink water. Many of them are better at it than I am, but it's important that we discuss that. Something I really love is that they now discuss the difference between religious fasting and intermittent fasting. And they work together with the Diabetes and Ramadan International Alliance. And they have a new figure which basically looks at the similarities and differences between religious and intermittent fasting. And then they discuss how to approach patients who are doing both kinds of fasting. So I really like that. And I think it's very helpful because many of us have patients who do both kinds of fasting, and it's important to know how to manage those patients. They talk about smoking cessation, which includes tobacco, e-cigarettes, and cannabis. And they say, slightly amusingly to me, since I live in California, not to use recreational cannabis in any form due to the risk of cannabis hyperemesis syndrome. Now, I have a lot of patients who do use legal recreational cannabis, and I do warn them about the cannabis hyperemesis syndrome, but most of them are not about to give up use of cannabis. So I just want to make sure that they're safe when they use it. In terms of psychosocial care, they talk a lot about screening for diabetes distress, depression, anxiety, fear of hypoglycemia, and disordered eating behaviors. And these are very important. They have 2 new tables, which are very useful in terms of illustrating all the psychosocial concerns and their relationships with diabetes-related outcomes in people with type 1 and type 2 diabetes. Section 6 is entitled Glycemic Goals and Hypoglycemia. A big part of this section is a new subsection that's about hyperglycemic crises. And this was published a couple months ago, but I'd encourage you to review it and make sure it's something that you're well aware of, because it discusses how to diagnose and treat DKA and the hyperglycemic hyperosmolar state. The section also includes figure 6.2, which I really like, which is a figure that's meant to help us determine target A1Cs for our patients. And I think it's a better figure than the prior ones that we've had. And it is pictorial, and it shows us as people change in terms of their individual health status and their functional status, how we should choose their A1C targets. And I would encourage you to look at this because I think in its way, it is more visual and perhaps more understandable than prior approaches to do this. Section 7 is entitled Diabetes Technology, which is arguably my favorite section because I happen to love diabetes technology because I think it really helps me help my patients. They recommend starting diabetes technology early, even at diagnosis. And I try to start it as early as possible because I think it helps patients understand their diabetes better from the get-go. They talk about all of the new research in the field, and there's been a lot. A lot of the data looks at use of automated insulin delivery systems, and most of the studies basically confirm their utility and safety. They do have a new table, which includes a description of the over-the-counter CGM devices that are now available. And they recommend using CGM when possible in patients with type 2 diabetes who aren't on insulin or on drugs that can cause hypoglycemia to help in their management. Section number 8 goes through obesity and weight management for the prevention and treatment of type 2 diabetes. And they don't really change much in terms of what we know how to do, but they do suggest using additional measurements of body fat distribution if the BMI is indeterminate. And then they talk about looking carefully at patients as they lose weight and doing monitoring of obesity-related anthropometric measurements at least every 3 months during active weight management therapy. They talk about weight stigma and bias towards people who live in larger bodies, and I think that's very important because patients often feel judged, and we don't wish for them to feel that way. They discuss, as they discussed above, the need to screen for malnutrition and make sure people aren't losing too much weight or too much lean body mass. And then they talk about continuing weight management pharmacotherapy beyond the initial weight loss, so weight loss is maintained. In terms of section 9, which is the pharmacologic approach to glycemic therapy, I don't think there's a whole lot that's new, although, again, they do a lot of discussion about the treatment of MASH using GLP-1 receptor agonist, dual GIP, GLP-1 receptor agonist, pioglitazone, or a combination thereof. Figure 9.3, as always, discusses the use of glucose-lowering medications in the management of type 2 diabetes. Now, I don't think that there's much that's different in this figure from prior years because we've really added in the notion of treating patients differently who have known cardiovascular disease, renal disease, heart failure, or high-risk individuals compared to patients who don't have those characteristics. But I really like the new figure because I think it's easier to follow. And at the bottom, they discuss mitigating the risk of MASLD or MASH. So it's a little bit more comprehensive, but thematically very simple. Figure 9.4 is the figure that looks at using injectable therapies in individuals with type 2 diabetes. And although the content here is similar to what it's been in prior years, it's actually presented in a way that seems much more readable and is probably going to be more helpful in terms of practitioners wanting to know practically how to start people on injectable therapies. One of the things they did was to remove the concept of a number that is evidence of over-basalization. So we used to say that if basal insulin doses exceeded 0.5 units per kilogram per day, that was evidence of over-basalization. And now, instead, they want us to look at if there's significant bedtime to morning or postprandial to preprandial glucose changes with occurrences of hypoglycemia, that's a good sign that a patient is over-basalized. That's the end of video number 2, and we'll rejoin with video number 3 and the final sections in the standards of care.